Now, this session is on aging well in Europe, and I'm looking at the demographics of this room, and I can see that it would be of personal interest to many of us in the immediate or medium-term future. So, we heard earlier about the changes in the way we need to think about health systems. We talked about individual citizen empowerment, and we've talked about citizen engagement and patient engagement tools. But in this session, we're going to look at ourselves in the mirror. In the same way the session just before the break held up a mirror to the health system and said, you are a bigger proportion of the greenhouse gas emissions than aviation and shipping put together. Now take a long, hard look at yourself and think about what you can do. We're now in this session going to hold up a mirror to our society and understand the implications. So I've got a fantastic panel that are going to help us talk this through, and I'm going to start with Jane Barrett from the International Federation of Aging. Now, Europe is aging. Do we really know what that means? Have we understood what the implications are for our society, for our economy, our infrastructure, our way of being and living?
Yes, of course we understand it, because Europe has been ageing for many decades, just like many countries around the world. I think what we don't understand as well is the external drivers alongside population ageing. Population ageing is a demographic upheaval. That's alongside migration, globalisation, urbanisation. And we heard in the last session, climate change. And so these are converging forces that are unprecedented in our time. I think that's one of the challenges. We seem to actually talk about population ageing as an outlier when in fact it's not. You know, we know that we're all living longer in many countries around the world, but it's the added life years in health that we need to be concerned with. We also know that non-communicable diseases, you know, about 90% of deaths are related to non-communicable diseases. But we also recognise that 80% of disability-adjusted life years are because of non-communicable diseases. The question that we need to be asking ourselves, Tamsin, is where do we invest? Do we invest in compressing morbidity or extending life expectancy? And it's an obvious answer. We need to compress morbidity, because if we actually invested in health promotion, prevention, non-communicable diseases, then in fact that would give us a social and economic benefit far beyond increasing life expectancy. And it interrelates with long-term care and interrelates with our healthcare systems. So, yes, we do know a lot about it, but it's about bringing together a joined-up approach around population ageing.
Thank you, Jane. As Europe moves towards 2030, when we're going to be the oldest continent in the world, is there anything we can learn from anywhere else in the world? Is there anywhere, a country or region that you think has really got to grips with this and understood how to change their systems?
No one has got to grips with it because it's evolving, it's a dynamic process. But we know that Singapore, for example, have invested tremendously in lifelong learning. That's a good thing. They also have invested in small grants, over 25, for as many years to learn more. They've also invested in social risk pooling. So in terms of trying to understand how much money you've got to live on post-retirement, there's a government fund. Japan, long-term care system, insurance, and it is now beginning to reap benefits. What's the return on investment? And of course, robotics. We talked a lot about carers across the course of the day, and we now have real evidence that robotics are going to actually pick up a lot of the LDA, ADL kind of care, the personal hygiene. And so we can invest in the human touch in the care and support of carers.
Thank you very much to Jane, and also giving us a sense of the future and where we go for this. And there are other places where we can look to explore, to learn more. Let me now pass the floor to Joost Korte from the European Commission DG Employment. We've got a brand new care strategy for the first time at EU level, which is really quite a milestone. Why is this the right moment? Why has it taken us this long to get to having a clear message at EU level?
Thank you very much, Tamsin. Yes, well, it's true actually that in the Commission we've been looking into the care sector since many, many years. but it always stayed at the level of analysis. So we actually know a lot. We accumulated data, how much a member state spent on care, how many people are working in the care sector. We've given also some recommendations. There are ESF, European Social Fund projects. But it's true that only in September we came with a package which is really composed of policy proposals. First time we move into the policy area. So why is this? I think it's a communication and 2 recommendations to the Council, both of which will be adopted on the 8th of December, so it goes quite fast. Proposals were made in early September. I mean, Ursula von der Leyen announced this a year ago in September 21. And then within a year, the package was on the table. I think a couple of reasons are not only this speech, but obviously COVID. COVID, I think, showed to everybody how important the care sector is, how fragile the care sector is, and that actually is true for the whole, also for health. I think it was an eye-opener. Not new in a way, because those people who read the analysis knew where the weaknesses are, but of course we saw it very, very clearly. That was definitely an eye-opener. I think also member states' preparedness to think about EU-wide solutions grew a lot, in that they saw that these are not issues that can be solved easily in a member state only, in an area which is obviously much more reserved for member states' competence. I mean, if you look at the treaty, it's not so easy for the Commission to come forward with policy proposals, but I think the political willingness, preparedness on the side of the member states has grown a lot because of COVID. Then there's also of course, the pillar of social rights, with an action plan to which the Commission committed itself, and Ursula von der Leyen in particular. So there are 3 principles there that concern the topics of today's discussion, and they had to be implemented. So that obviously we're doing. And then I think finally, I mean, aging. Of course, we're not blind. Aging is having a huge impact on the societies, and that filters through to the EU level. Even though aging, I don't think you find it in the treaty as an issue that the EU should deal with. But as we see, you know, the world around us is changing, our own societies are changing, and the European Union is a beast that then adapts. So we get into areas where we have so far been a lot more reserved.
Thank you, Joost. And just to give us a very brief highlight, what do you hope will change with this strategy? How would we see and experience something that's different?
Well, as I said, there are 2, it's a strategy, but it is also 2 legal acts. That's quite important. There are 2 recommendations. Okay, they're not legally binding acts because we can't. The treaty does not allow the Commission to put forward binding legislation in this area, a directive or a regulation. I mean, when everything gets very hot, it becomes always fluid. So who knows? Huh? I had never thought that we would be going into energy, for instance, with a legally binding proposal. So maybe this may happen over time as well, if the lawyers become a bit more flexible. But for the moment, it's a recommendation. That means that ministers commit to it, and they will do this on the 8th of December, and they don't do this lightly. So I think there is a true commitment through these legal acts. Now, there are 2 elements, I think, which I would like to mention. I think there is the obvious point of access to the care sector, the quality of the care sector, and the affordability, where the recommendation contains a lot of criteria and suggestions for member states how to improve all 3. And secondly, and that's maybe also quite a new dimension, it's the people working in the sector, the carers. So a lot of the recommendation focuses on them to improve their working conditions, to make it more attractive to work in the sector, to do more about their skills, including the recognition of skills, because you can be a very good carer in one country, it's almost impossible to move to another one because the diplomas don't match, and it's not a regulated profession at EU level. And then there's also a dimension there which is a bit subsidiary but nevertheless important. It also has a dimension of legal migration from third countries. Because if you look at the shortages that are there already today, and I'm sure Stacey will talk a lot about it, but in our paper it says 80%, today 80% of the care, long-term care, is done by families. So, which also has a lot of impact on the way our societies are organized. It's a huge gender issue because we know very well who in the family is concerned about. And so, and that then brings you into also the sort of positive side of these investments, because you could easily imagine that with the right investments, the right policy mix, this can actually trigger growth in our economies. It's not only cost. If you do it well, this is a huge potential also for growth of the economies and for more fiscal income for the member states. So those are, I think, the essential points where we hope changes will be made. We will obviously follow up. The recommendation, if you read it, it's full of follow-up points, reporting. Commission will be very tough to scrutinize what member states are actually doing.
Thank you very much. And let me now bring in Stacey Ingemos from the Eurocarers. You know, you're the executive director there, and I know that for years you've been raising the issue of the role of carers, whether formal or informal. And here we are, we've got a strategy on the table. So here, let me help understand what is the relevance of dealing with this at EU level. Why did it need to be addressed at that fundamental top level?
Thank you, Tamzin, and good morning, everyone. Yes, we've been pushing for an EU initiative on the topic for probably more than 15 years. Well, first of all, why do we need an EU strategy? As we just heard, you know, all of the member states face extremely similar challenges in terms of the growing prevalence of chronic diseases, the growing demand for care, the declining supply of both formal and informal carers, because of difficult working conditions, inadequate training, and as a result, obviously, a huge quality and sustainability challenge for our care systems. Also, all member states tend to rely very heavily on informal carers or family carers or unpaid carers, as they are known in different places, but essentially family members, friends, and neighbors who provide usually unpaid long-term care. And obviously, indeed, it is a strong gender dimension. So from our perspective, it's a major achievement that we now have an EU care strategy. I mean, 8 years ago, when I joined Eurocarers, member states didn't want to speak long-term care together at EU level. And now, 8 years later, we have common goals. So at EU level, quite frankly, I've been active at EU level for probably 20 years now. 8 years is a fairly short amount of time. So that's the first reason. The second reason, of course, is that population exchange trends tend to coexist with, many older people choosing to move, from northern countries to southern countries, for example, with their carers to, maybe have a better quality of life, better weather, and also younger people who will decide to move abroad to study or work. So people move around, across the EU, and that raises questions when it comes to long-term care about the portability of these rights and the eligibility of accessing support measures across the border. So for all of these reasons, it does make sense to have at least a coordination mechanism at European level in the field of long-term care. Yeah.
Thank you, Stacey. And the long-awaited care strategy is here, and given that the pandemic put in very sharp relief the risks and weaknesses of our long-term care system, where for many older people, actually being in an institutionalized care home was a higher risk factor of getting and dying from COVID. So we saw the gaps in the system. What are the risks associated with this new care package? Where are the gaps that are still not being filled?
Yeah, well, first of all, again, it's not every day we say this, but the Commission did manage to tick many of the boxes we were expecting, so kudos to the Commission for that. In terms of the challenges, well, the strategy is only a strategy, it's only a plan. So now that, member states are about to approve the strategy, endorse it, we need to see how it is implemented, how it is interpreted across the Union. As I said, what we expect is a redistribution of responsibilities between individuals and the collective. We need to address the over-reliance on informal carers because, informal carers tend to face a long list of challenges on their own as a result of their caregiving in terms of their ability to access education, employment, in terms of poverty, social exclusion, and also negative health outcomes. So we need to address that. And one of the risks is now that we have the strategy, and the strategy does recognize the need to support informal carers, we want to avoid a situation whereby member states would shift away responsibilities from professional care to informal carers while, throwing a few, rights here and there, and then, problem solved. Obviously, that's not what we want to see. Yet, it's going to be impossible or extremely difficult to replace informal care by professional care altogether, because the value of informal care far exceeds current budgets devoted to professional long-term care. So we'll need to maintain some, some portion of informal care in the care mix. And so another risk or another challenge will be to decide what is an adequate mix between professional and informal care. And how do we also maintain choice for informal carers about to what extent we all want to be involved in the provision of long-term care, and whether actually we want to be involved in the provision of long-term care. The third risk, obviously, is the elephant in the room, is the sustainability. How are we going to pay for all of that? I'm not an economist myself, so I'll leave it to the economists in the room. And the fourth challenge we still see, or the limitation of the strategy, if I may, is the fact that EU institutions and many policymakers continue to approach informal carer exclusively as a barrier to other productive activities, so money-making activities, essentially. So in other words, the value of informal care, or the value of trying to address informal care only lies in ensuring that people can be productive. But actually, obviously, the provision of care is much more than that. I mean, that's part of the human experience, and we also need to recognize that it contributes to social cohesion and intergenerational solidarity, and we need also that in our society. Yeah, I'll stop there.
Thank you very much, Stacey. Let me now invite our speaker who's joining us online from Copenhagen, and that's Natasha Azzopardi-Muscat, the Director of Health Policies and Systems at the World Health Organization. Natasha, welcome, and thank you for joining us remotely. We've been talking here about how, we heard from Jane, is the goal is to improve healthy life years and to compress the morbidity towards the end of life. And we also heard that Europe is not really got to grips with the implications of aging, although in the earlier session we heard that actually we've been increasing life expectancy every 4 years. So this is something we should have planned for. Can you tell us, have our health systems ready and set up to deal with an aging population? Have we been sufficient in our planning?
Thank you, Tamsin, and it's a pleasure to be able to join you briefly in between events, and indeed it's a fascinating conversation. So let's just start by celebrating the fact that life expectancy has been increasing and not taking this for granted. In fact, what we are seeing in the aftermath of the COVID pandemic is that in a number of countries, life expectancy is sadly stagnating. So I think we should take a moment to recognize the success and achievement that the European region has had. Of course, we are not only concerned about adding years to life, we want to make sure that we also add life to years. Aging is inevitable, but healthy aging requires us also to invest very much in prevention and in ensuring that people can have access to all those factors which we know will enable them to age more healthily. The second point is really around, I think, debunking some of the myths. We know, for example, that it's typically the last year of life that is the most expensive. And of course, it's a good thing that most people have their last year of life increasingly at an older age, but not everybody has the privilege of achieving their last year of life at an older age too. In terms of our health systems, let's be frank, health systems across the European region are struggling. They are struggling badly. They are struggling because they are still seeking to recover from the years that we have gone through because of the COVID pandemic. They are struggling to catch up with backlogs, but there are also other emergencies in Europe, not least the war in Ukraine, for example, that are putting pressure on health systems. But not all health systems have coped in the same way. What do we see? we see that those health systems that were able to invest, for example, more in strengthening primary healthcare were able to cope far better, whilst health systems that are still very, very dependent on siloed hospital specialized care approaches were not able to cope so well during the pandemic. And this in turn is of course part of the preparation for an aging society, a society that is going to spend part of its life with chronic comorbidities that are far best tackled through a multidisciplinary team outside the hospital setting. We want to keep older persons away from hospitals until they really have to be there because it's the only place for them to be. And in that case, we need them to be there for as short a period as possible. And then we come to the issue of care and long-term care, which previous speakers have spoken very articulately about. And we are seeing that more and more member states are now seeking to invest in rehabilitation, palliative care, and long-term care. And let me just say that within our service delivery program at WHO Regional Office for Europe in Copenhagen, it is no coincidence that rehabilitation services, we will be launching a landmark report next week. Long-term care and palliative care are the three areas that our countries have asked us to really step up our work on, because all countries, irrespective of their level of development, are facing challenges and are seeking to develop joint solutions. The challenges lie also inherently in the lack of a care workforce. Because Europe is aging, the health workforce and care workforce is aging too. Part of the solution has been to try and import a care workforce, but that in itself is not sustainable, in addition to the ethical dilemmas that it is creating. And this is why we need to really think out of the box and think innovation. But let me not forget, for example, mental health. Last week we had a meeting of our mental health coalition, and one of the work packages that we are taking forward is the mental health of older persons. And with this, for example, we have dementia on the agenda too. Again, a huge area of concern that requires care and support, and where we feel that our health systems are struggling to keep up and are chasing behind the curve rather than being ahead of the curve. So I think the message is, yes, we need to really think, what are the health systems that we need in a digital era with an aging population, with a finite health and care workforce, but with the opportunities also that technologies offer to us. But this means that, for example, we need to very much invest in the digital health literacy of older persons too, to enable them to benefit from the opportunities that there are available. So those, I think, would be a few thoughts that I would like to leave with you. Unfortunately, I will have to jump off at 1 p.m., but thank you very much once again for inviting me to be here and share the perspective on behalf of the WHO's Regional Office for Europe.
Excellent. Thank you very much. This is a very useful intervention. We're going to now open the floor for a short Q&A before we go on and invite our next speakers to join. Is there anyone who would like to ask a question based around what we've just heard? We've set out very clearly the changes and the challenges that gives to our health systems, our society, about an aging Europe, an aging population, an aging workforce, and the burdens that has put on carers. We've heard that the 80% of care is delivered within families, and that largely falls on women. There are gender aspects around that, not least because the women who take on that care then experience higher risk of poverty. They don't get a pension because they haven't contributed, and that work is just not valued. So lots of different issues and challenges put on the table by our speakers. Would anyone like to ask a question at this point or raise a contribution? Yes, if you'd like to stand up, please, and introduce yourself. Thank you.
Okay, thank you. Ber Omer, European Specialist Nurses, Executive Director. A very interesting and very relevant topic at the moment, the aging and the elderly. And we often speak about the role of the healthcare professionals. But what we do experience, that often nurses are not facilitated in the education competence. Take, for example, in the palliative care. There are groups specialized in palliative care. They have their own education structure, they have their own curricula, but if you go to the hospital, then they say, well, you got your 8-hour shift, you have to work for 8 hours, and the rest is your responsibility. So I know it's a nurse's responsibility to be competent. It's a very personal one, but they have to be facilitated. Also, if you just take them in the 4 hours, five days a week, they wouldn't be allowed. So I think in this whole domain, in the care strategy, we also need to include budgets and really invest time for them to be competent. Otherwise, it's a brain drain, and then it's becoming by the endangered species, and we need to avoid this.
Thank you, Bear. I think that's a very useful point, which is we need to look at our health workforce as a precious resource, and not just people who need to deliver the work in the sector, but also invest in upskilling them and giving them the opportunity to take on the special skills that they need to go forward. And Jane, yes, please respond on that.
I felt it's very important to respond to your comment. You know, for 2 years, many countries around the world were banging saucepans in celebration for the work of the frontline workers, right? Every Friday it was, you know, where I was living. And yet the saucepans have stopped banging. And yet the burnout of nurses and other frontline professionals continues. So when we think about healthcare system reform, then part of my thinking is that we really need to invest in the continuing education. And I understand what you're saying, that it is our responsibility as health professionals. And yes, we need frontline professionals to be expert in what they do. And if they're not, then we're the first to complain, the general public. And so I would certainly support and be a strong ally, you know, in calling on governments, member states, to invest in the continuing education of healthcare professionals. Otherwise, we don't have health system reform. So thank you for your question.
Thank you. Joost, can I ask you to pick up on that? And Stacey, this measure that we need to look at our health and care workforce, not just for because they get paid for the hours that they do, but we're not investing enough in giving them the time and the space and the paid time off to go in and upskill and move to that next level. And, you know, as Jane has said, we've stopped banging on saucepans, but this is a way that we offer a career path and a recognition. Is that something that's foreseen, or is that another one of those things that is left to either national level or individual employers?
Yeah, no, but I agree very much with what Jane said, and also with the question. I think this is, I think, fairly consensual that more investments are needed in the workforce, and also the work needs to become more attractive, which means better pay and better working conditions, including upskilling, reskilling, not once, but forever. It never stops. And that, by the way, is not only true for the nurses. It also applies to many other professions in the European Union. So more investments indeed, and make it more attractive for people to work in that sector, because I mean the perception is not very positive, honestly. So that's very. But I think member states realize this, and they are prepared to work on this. And again, the recommendation contains a lot of good ideas and suggestions how to do this in practice, so that it doesn't stay, you know, at the level of nice interventions in conferences, but that something is actually happening on the ground. If you look at the total amount that member states spend on care, on long-term care, it's 1.7% on average of the GDP. But that's the average of the EU. That is for very rich countries to very poor countries. It's not so relevant, I think, as a figure. It gets a bit more relevant if you compare it to other averages, like pensions. On pensions, the EU 27 spend on average 11.6%. So 1.7 on care, and 11.6 on pension, and 6.6 on healthcare. So there you see that care is really low. And if you go a bit deeper into that 1.7%, in fact, most member states spend less than 1%. And why? Because they rely on Stacey's people. Huh? This is the way out, of course. So I think whatever way you look at it, and I'm not in any way proposing, you know, that member states should acquire more debts forevermore, because the demand is maybe also infinite, but definitely more needs to be spent in those countries that are so low at the moment, in order to make that the working in the sector more attractive, and we need these people.
Thank you.
Could I just make a point?
Yeah.
You know, the investment is also proportional to the disability adjusted life years, you know, to the functional ability of the population, and we just don't have good data on this. So we're investing in 1.7 or whether it's 0.6, or we actually need to start joining up the dots to understand what is the percentage of informal carers in the workforce, what's the percentage of frontline workers, you know, what's the percentage of people that have a fall and have a premature admission to hospital. So it's really a joined up approach that we need. Sorry, Stacey.
No, that's okay. I agree with you that we certainly need more data. I would at the same time say that we have enough data to act, you know. Maybe I completely agree with what's been said. Maybe to add to that and to illustrate that, out of the roughly 6.3 million people who are part of the long-term care workforce in the EU today, 70% are personal care workers with no nursing degree or very limited training. So when we speak about quality, obviously we need to invest in training. I mean, there's no way around it. So just to agree with all of you.
Thank you. I'm now going to bring in our next two speakers to add a little bit more to this. So I have with me Sean Lybrand from Amgem, and we talked, Jane gave us right at the beginning these big statistics. It's the NCD burden. It's a bit like it's the economy issue, but it's the NCD burden. If we can keep people healthier longer, that's surely going to work. So if we could identify and manage the non-communicable diseases earlier and better, how would that support the goals of the long-term care strategy?
Sure, thank you. I do think one of the goals of the long-term health strategy should be to avoid having people in long-term care for as long as possible. And Jane picked up on that with respect to the compression of morbidity. A previous speaker, so Kieran, I love the fact that social care and healthcare lines up, because then you have a line of sight over the budget, and you can take the Kaiser Permanente-like approach that was mentioned, which is if you can manage people going into the system, you can also manage costs. So from my point of view, the idea that we have a comprehensive long-term care strategy in Europe is excellent. It needs to be supported by a long-term primary and secondary prevention healthcare strategy as well, which of course, at least in cancer, Europe has done with the Beating Cancer Plan that they announced a short while ago. And as you know, a beating cardiovascular disease plan is hopefully going to be tabled at some stage. So by joining up particularly preventable conditions through identification and management of non-communicable conditions, there is a cost to that, but it's cost effective. We must remember that healthcare interventions are some of the only things that are assessed for cost effectiveness across the whole of the government system.
Thank you. And where do you see the role of innovative therapies and their modalities of delivery fitting into that broader picture of supporting individuals to better manage their care?
Sure. This might seem, from an industry perspective, to be different, but the importance of the non-communicable disease approaches is that there are many, many medicines that have proven to be cost effective in managing at the secondary prevention level cardiovascular disease, diabetes, chronic kidney disease. So I think it's the importance of trying to blend in secondary prevention approaches, of course, which primary care gives, but also trying to help engage people in their own health. One of the issues with chronic disease as opposed to rare disease is that chronic disease will sneak up on all of us. Most of the chronic diseases that we can have are things that don't have symptoms until later stages. The first thing somebody knows about a heart attack often is a sore arm or that, and the first heart attack can often be fatal. So the idea of managing care and ensuring that cost-effective medicines and other modalities are used early in care will hopefully leave long-term care to the people who really need it for as long as possible.
Thank you. Andrea, let me bring you in from Edwards Lifesciences, because again, we're talking about how do we deliver on this vision, or we spend an insignificant amount of our money on prevention and promotion, and we need to sort of shift our focus and our spending on this. So as a medical technology innovator, where do you see that the piece of the puzzle that innovation could deliver, and what do we need to change now so that we're more prepared for the inevitable aging of our population?
Yeah, let me say a couple of comments very briefly. I think that we all understood the European population is aging. So we keep studying, rediscussing. By the end of the day, this is a region of the world that is dramatically entering in an aging phases. It's not anymore an issue of a demographer. I think the European Commission, if I well remember, in the early 2010, launched an active and healthy aging innovation partnership. That was the first time that was really putting in front of member states, policymakers, decision makers, different societal the issue. After 10 years, we know that, we got it. So this is great. What is the major issue? That we try to address that with healthcare system that they were designing 50 years ago. The COVID story, the pandemic, has simply accelerated a slippery slope. Cioè has put maybe in a couple of years what would have happened in the next 5, 6 years. But fact is that today even we start to say, well, we need to pay maybe 100 euros more nurses, fantastic. Doctors, 150 because they are doctors, maybe, fantastic. But it's not just having more doctors better paid with that organizational healthcare system. It doesn't work. We will never address that. That's the real challenge that we do have. We like to invest in primary prevention, keep fit, eat well, Tai Chi. By the end of the day, we don't want to get one vaccine in secondary prevention to elderly people. We want to put in a real interventional prevention. That's not the issue. When they enter in an hospital, they found what already OECD informed us in 2017 about the wasting in the hospital system. Elderly people, they enter, 20% of intervention are poor wasting of money. Processes are old. That's the real. Technology that I use are old. Repetitive. How we found it? We found them. I'm not an economist either, but we fund them if we cut that wasting and invest in innovative technologies. Technologies that are able to, A, improve health outcomes, which means individually and collectively, make elderly people or senior society more independent, better contributor to society, taking them out from the hospital faster, but better, and third, which is even more important, increase the level of the population health. So collectively is a benefit. That innovation in processes as well in technologies can have a real impact. And I think that most recently with the Innovative Health Initiative, the European Commission that has launched now is 18 months, 2 years ago, that's the way, test and trial innovation in order to adopt. Generate evidences, but test and trial, not remain an academic problem. The good news is that technologies are there to make that. Minimally invasive transcatheter, digital solution we heard early this morning. But test and trial, make use of them. Clinical decision support system, the real element of the digitalization. Digital is not only how we can build a mega database, but clinical decision support system in the different phase of the patient journey. These are critical. Test and trial, let's make use of them. Adopt, invest in them. And then we were able to have maybe in a couple of years the same session where we start to measure the outcome of all that.
Thank you. Let me see if we want to have a question from the floor or a contribution on this conversation about healthy aging and our overall approach. We've heard there about using technology better to test out and try things to address failures in our system and our systems which were built for the health problems and the life expectancy of 50 years ago. So it's a big rethink that we need to do. Is there anyone who would like to contribute from the floor? Yes, we will give you a microphone. If you could please stand up and introduce yourself. Thank you.
Thank you. Hi, I'm Nancy from the UK mission to the EU. I really appreciate the panel and everything you've discussed. It's been really interesting. And what I'm really interested in is the preventative care. But I think part of it is a mindset change for the public, as well as obviously the healthcare workers, doctors, nurses, etc. So I was wondering if the panel had any reflections on how we bring the public along with this narrative about investing in their own healthcare and some of those preventative measures. Thank you.
Thank you. I think that's an interesting challenge that Jane, I might put on your desk to answer. And let me also see if we have any other inputs for our panel to think about. Yes, we have a microphone that we'll bring to you here in the front. Just wait, the microphone's coming to you. That's it.
Merci. Merci à tous. I try my best English.
Okay.
Well, all this is depending on how we can maintain those people at home. And that is all about investment, of course. And then data has also a duty to offer some incentives. Of course, it's a market, but how people will be able to sustain such an investment on personal ground. This is a big elephant in the room. Thank you to help to answer.
Thank you. So you've raised a very interesting point, which is where the burden is, whether it's on the individual or in society. And in health, we've very clearly said that health systems are there to manage the risk for everyone. But on long-term care, the burden is falling, as Stacey says, 80% on families, largely women, in formal care. And if we're going to keep people independent in their homes with dignity longer, then again, that's investment, either in skills or training or adaptations of buildings and homes. And you're asking the important question, where does that investment lie? Who's going to pay for it? And that comes to the point that I think I'd like our panel to reflect on, is at what point are we going to recognise at European level that a functioning long-term care system is a public good and not an individual responsibility to sort out, and then address it with the same level of focus, investment and support as we do our health systems? So Jane, let me start with bringing to you this issue about how do we get the public as involved and invested in taking care of their health over the long term as we want the systems to do.
And thank you very much, Nancy. I think it's a really complex but great question. And the utopian response would be that this is an intergenerational theme, right? And I say that because we know that physical exercise, mental activity, etc., starts really at a school-based age. So, that's what I would say in response long term. But it really requires investment up there. I think the most important message is that we've got the wrong narrative going out there, about investments in ourselves. Because at 20, did I really think that I was going to die of heart disease? No. And so we have the wrong narrative because we don't invest, once again this word, we don't invest in the public health messages that are going to impact you at your age. And we can just look in terms of our whole saga in vaccination as a good example. Older people, what they're told is, it's flu season, go and get your flu vaccine. That is meaningless. We know it's meaningless. So we've got to actually understand what is the effective messaging for that target group and how do they receive that message? Do they receive it on TikTok or Instagram, or do they see it on a poster board? So 2 responses, intergenerational, absolutely. But shape the narrative for the targeted population, and then you're going to get a return on investment.
Thank you. Who on the panel wants to pick up on that bigger picture of... okay, Sean wants to come in, I'll bring in Andrea, and then I'll come to that side.
At a panel that Tamsin hosted a while ago, the rapporteur said nobody wants to have a little bit of cancer. And the issue with that is that people treat cancer very seriously, despite the gradient of what cancer is. The importance to me on primary care, Lubna raised something earlier today about AI, is that we can use AI and data to be able to not say a person who will be likely to have something, but the type of people who are more likely to be impacted by that. So for me, building in the idea of using data for good, health data for good, to actually point to people not only of the fact that they may be likely for a particular issue, but also the potential consequences. People are more likely to act against a negative stimulus than a positive stimulus in that regard. So how do we, as Jane was saying, early enough be able to develop lifelong healthy behaviours? And it's complicated. I think it's complicated by our lifestyle. But the fact is that NCDs are what drive costs and outcomes in Europe and most other high-income countries in the world. So that is an important area to be investing in as well.
Thank you.
Yeah.
Andrea?
No, I was thinking the gentle lady put a really excellent question, because you were touching really the core is the crossroad between healthcare budget and social care budget. That today are, you can say, siloed, separated, but the patient live a continuum. It's not, they don't get like, you know, now I'm pushing on the healthcare, now I'm pushing on the social care. The people live. They just simply live. So they cross different phases when they have to deal with the disease. And what I was talking before, what we call capacity enhancing innovation, innovation in processes and in technologies that is able to capture this continuum, are not isolated for one disease. When you talk about cardiovascular diseases, the dramatic things today, that was my call before, is not that, you know, we don't treat enough and well patients, but in some heart valve disease, we have people in Germany, France, in UK, that are dying in the waiting list. They are diagnosed, they know, and they don't even forget which type of treatment. I'm not even saying, they simply die because there you say that's a process that doesn't work, as innovation in processes. It's not anymore innovation in technology because they don't get even the opportunity to get the technology. Which is the right balance between improving the processes, early screening, early detection, monitoring, so risk stratification, understand which type of population will enter in a more risky phase afterwards, and then the technology that can free the people faster from the hospital, better outcomes, regaining normal life, not with 1 year rehabilitation, but maybe with a couple of weeks of rehabilitation, things like that, and re-entering in a positive cycle, being independent, as you were calling. These type of things demand a reflection, and what I was saying, test and trial immediately, because opportunities are there, technologies are there.
Thank you. Stacey, let me bring you in here to pick up on this broader issue of, you know, how we manage that relationship on what falls on the individual and therefore on their family to provide that care when they need it as they get older. And yet in other areas, in pensions and health, we recognize the value of having a collective approach. How do you see that battle? I mean, you talked about it's taken 8 years to get a strategy for care at European level, but the next level is recognizing that we need a collective response to what's currently sitting on individual shoulders. How hopeful are you?
Yeah, that's a difficult question. Look, again, the way we see it, now we have an open door. People are willing to at least discuss the issue, which is already a big thing, you know. But we see more and more member states indeed paying attention to informal carers as a way of now officially financing, in a way, care systems. We've been relying on families for decades as a form of cheap or free workforce. And now we may run again the risk of creating a few rights for these people, you know, at limited cost compared to the investment it would take to replace them, and then continue to rely on them. And so in terms of that balance, what we really want to ensure is that we also invest in the portfolio of alternative options, because one of the key drivers of the high prevalence and the high reliance on informal carers in Europe is the lack of alternative options. Community-based care, home-based care, as we heard. You know, I was very pleased to hear about the Irish plan and you know, the objective of, you know, investing at local level. That's what we want to see across Europe. The key challenge from our perspective is what we heard about the need to review, you know, old-fashioned processes and probably make some benefits there. The need to invest in a new ecosystem of, you know, in the care delivery, and at the same time, the need to recognize and support informal carers, plus prevention. All of this needs to happen at the same time, and that's the real challenge. So we have a few ideas about how things could be financed, but probably I would speak for an additional half an hour, so I'll stop here. Thank you.
Thank you. Joost, let me bring you in on, I think, something that Stacey has touched on, which is that the burden of care and the fact that we have for decades relied on unpaid carers to deliver it. Now, the care strategy you mentioned, it creates some rights, it talks about paying conditions for workers in that area, but long-term care strategy is usually delivered or organised at local government level, and they procure usually on the assumption that people who work in the care strategy are on minimum wage. That's the only way that it is affordable for the local service provision. What you're talking about is investing in that, training, offering better quality work. If I was a policymaker, in the back of my mind, I would see, glaring red sign, more money is needed. And if half of Stacey's workforce actually said, well, you could pay us for what we do, that's even more money. As we're looking at a cost of living crisis, you've said that member states are coming to the table. Are they not afraid of the fact that the inevitable result of this conversation is more money is needed, more investment is needed? Or have they recognized that, just like with pandemic prevention, if you cut corners now, you pay for it later? Are they ready for that conversation?
Yeah, no, that's a very good question, and I think there's not one answer to this. I think, honestly, Tamsin, I think one thing which is really true is that it needs to be, of course, as previous speakers have said, an integrated approach. And we were struggling with it ourselves in the Commission, because when Ursula von der Leyen said, I want a care strategy, and I said, yes, but what about health? And how do you, where do you draw the border between health and care? And you see that the strategy is actually early childhood education and care, the Barcelona, so-called Barcelona targets in our jargon, and then we take an enormous leap, and then we go to the long-term care. The whole middle part is, because in our world this is a different DG, and it's also different ministries and different different actors. So this is obviously a handicap. I agree. It needs to be integrated, because if we continue with the health system as it is today, it will just deliver more people into the care, without any doubt. So we need to do that as well. On top of it, however, I remain convinced that more investments are needed. I mean, again, I'm just quoting here the work of my colleagues. They've done some extrapolating work, and they have come to the conclusion in the communication that something like 13.6 million jobs extra will be needed by 2030 if we really want to have a well-functioning long-term care sector. Where are these people? I don't see them. We already have shortages in other sectors, so that's why there the answer needs to be surely more money. They need to be paid better skilled, better education, more possibilities to move around between member states and regions of member states, and then also surely we will need migration. Otherwise, we will never fill this gap, whatever we do. Is there? And then, of course, the question is how much money. These are, at the end of the day, choices that are made. I agree with you that the minimum wage is sort of the understanding for many decades. This is okay for the nurses, but why? Why? I personally don't agree with that at all. I think they need to be paid a lot more. But the same is true maybe for the policemen and the teachers. I don't know. All these sectors of our society that we know now, in particular, and COVID as a wake-up. It hasn't actually changed all that much, but we were confronted with the reality of these sectors that are so important for our societies. In my own member state, for instance, I know this, they spend, according to their official figures in the Netherlands, 4.4% on care. So obviously, the minister, when she came to speak to Nicola Schmid, said, "Oh, I can't spend any more. I'm already, and if I do nothing, I think they did some. It will go to 20%. So this is obviously not an option. I mean, I don't think you can really make so. But then there are also ones who are below 1%, and they should move. And then in the Netherlands, they need to possibly do a bit more on the health sector in order to avoid an everlasting increase of the cost. And finally, as you said yourself, I mean, it's the choices we make at the political level as societies where we want to invest. And these choices are not easy, and I'm happy I don't have to make them. But the direction of travel is, I think, pretty convincingly put forward in the strategy.
Thank you. I mean, I think that's you just described with that anecdote from the Netherlands what is, I think, the fear is when ministers or policymakers sit and actually look at the numbers and then do some kind of extrapolation to say, well, this is what it would cost, then I think their automatic reflex is, how do we cut it? How do we cut the entitlement to support now? Because if we might be able to afford it now, but in 5, 10, 15 years, we absolutely could not pay the 20%, etc. So we must stop the rot now. But the way they approach it is that means we cut entitlement rather than some of the things that we've talked about on this panel, which is using smart tools and innovation to help people manage, much better prevention and moving upstream, because that's slow, it's difficult to manage, it involves many other parts. So I think the automatic reflex has tended to be, up until now, how do we cut things? So I'm going to invite Jane to close our panel and wrap up. You opened it by challenging us to say we are looking with eyes from the past and we haven't got to grips with the way things change. And we've had 30 years. This has been a slow pandemic coming at us. What would be the advice you'd like to leave us to address some of these difficult issues in a way that's inclusive rather than automatically closing down the options because of fear of cost?
Thank you, Tamsin. Today we are in the second year of the United Nations Decade of Healthy Ageing. There are 4 action areas: primary integrated care, age-friendly cities and communities, and I want to acknowledge Ireland, because Ireland is the only country that has been submitted a plan to the WHO for an age-friendly Ireland. So there's some indication there. The third is combating ageism, and the fourth is long-term care. Each of these action areas connect with one another, and that's the very essence of what we've been talking about today. What's most important is the enablers. The enablers are voice and engagement, which is what we've been doing here. Leadership and capacity, which is what you do. Monitoring and surveillance, and that's where we need the experts in academia. And finally, the coordination and multi-stakeholder engagement. Friends of Europe is a very important and interesting summit because it brings together cross-sector and cross-disciplinary approach. So I am optimistic of the future. I'm not pessimistic, because we have the best minds and thought leaders, who I'm sitting between, that understand the issues and are investing in joined up government and joined up portfolios. What we perhaps need more of is summits like this, which enable us the space to think, to connect, and to partner for the future. The answers are within us, so be optimistic as I am. Thank you, Tamsin.
Thank you very much to Jane and to all the members of our panel, to Joost, to Jane, to Stacey, to Natasha, who joined us online, to Andrea and to Sean. So let me just close our Health Innovation Summit, which I think, we had this red thread that moved through it all, which was innovation in thinking. Yes, I'm sorry, did you have your hand up? Did you want to say something briefly? We can get a microphone to you, but it has to be very brief because we're running out of time. Please stand up and introduce yourself.
Hello, my name is Mihai Todirica. I have only one short question. There are many national health systems. Do you think that some of their competencies should be transferred to European Union and have maybe one even European health agency, just health agency?
Well,
I'm sure if I asked 5 people on the panel, I'd get 5 slightly variations on that, and there's no way we could answer that in a minute. But if anyone wants to take up the challenge, feel free. But Joost, go ahead.
I mean, your guess is as good as mine. I think, the treaty says today that we cannot do that. So bureaucratically, the answer is easy, no. Unless you change the treaty and you transfer the competences to the level of the EU, and then legally speaking, institutionally speaking, it would be possible. We had a conference on the future of Europe. Very big conferences. I didn't see this anywhere. Nowhere. Well, there was a lot on mental health, There was a lot on young people, which was good, and we're taking that forward, but there was no desire, I didn't see any desire to do this. So politically, there doesn't seem to be much support for this. If ever it would happen, then I think you need to create a completely different commission, because we have very few people actually. I think I'm talking here now a lot about, long-term care, but I think I don't even have 5 people in my own department. Now, obviously, we have a lot of support from member states. We have the important stakeholders, scientific research, so we do a pretty good show. But the idea that we would be managing, or the colleagues in DG Santé, the health sector for the whole of the EU is pie in the sky, if you ask me. Also because the differences are so enormous. It will be very hard for us to invent a system that is applicable and useful and payable, affordable for all 27 member states, regions. I cannot recommend it today, but who knows? Huh? Next generations, things can always happen.
Thank you. I am now going to conclude because we've come to the end of our time. I just want to remind something that came through earlier today, which was during the pandemic, what we had was urgency, and that urgency created fluidity in thinking. Fluidity in the way that we approached what we can and cannot do, whether it was healthcare or anywhere else. So I want to encourage that fluidity of thinking and flexibility as we move forward, because the 3 areas we looked at today, the citizen engagement and empowerment, the green transition and aging, all require a different approach, a new way of thinking. So if there's one message I think that's come through very strongly is the pressure cooker that was the pandemic offered us that opportunity of fluidity of thinking. We will need that to approach the challenges that our health systems and our societies need to deal with in the future. So thank you to this panel and our previous panels for helping us to think through it. And thank you to you for your very active participation and engaging with these big questions. And we see you at another Friends of Europe event very soon. Thank you.